All right, I think we can get started. Are you able to hear me okay, everyone? Yes? Okay, great. Um, so welcome everyone to Geriatric Medicine Grand Rounds. We have a special guest today who is familiar to many of you. Dr. Matt Mesias did his internal medicine residency over here at the University of Washington. And then he was one of our geriatrics fellows. He graduated back in 2018. It feels like it wasn't that long ago, but wow, time is flying and flown, and there's been this whole pandemic since then. So we have a weird space-time continuum going on. But we're so glad that you're back. Since he left the University of Washington, Matt has just really thrived at Stanford University. He's a clinical assistant professor there, but he's done quite a bit to enhance and build geriatrics education there. And he's currently a Geriatric Academic Career Award recipient, which is a pretty highly competitive award for educators focusing on interprofessional education that's funded through the Health Resources and Services Administration. So, Matt, we're so excited that you've come to share with us what you have to say about age-friendly care. And I'm just glad to see you. I'm always glad to see you. So thank you so much for joining us.
Thanks, Kate. And good morning, everyone. Thanks for having me. It's really an honor to come back. I learned a lot there. And I actually think about all the things I learned almost every day when I'm in my clinical practice and teaching and doing all this stuff. So the title of our talk today is Elevating Age-Friendly Care for Older Adults Through Community Partnerships and Geriatrics Education. But when I was putting the talk together, I actually thought it probably should be a more appropriate title would be Elevating Age-Friendly Care for Older Adults Through Community Partnerships and Geriatric Education. Hashtag all the things Kate and y'all taught me that I took to California. So as we'll go through this, some of the work I've been up to since it's been 6 years. It doesn't feel like that, but I guess it is how time works. So I have to disclose that this work is funded by the Geriatrics Academic Career Award, HRSA, and we'll talk a little bit about what we've been up to through over here, and here are our objectives. So the next 45 minutes or so, I'll reflect on, for you all to reflect on how you ended up in geriatrics and how we can replicate those experiences to grow the pipeline of geriatric trainees. We'll identify how developing community partnerships can advance age-friendly care to those without access to geriatrics. And we'll switch it up a little bit and talk a little bit about how formalized age-friendly care pathways for geriatric trauma can potentially improve delirium outcomes. So this isn't a geriatric grand rounds without the obligatory "there are more older adults and the world is aging" slide. So if you had that on your bingo card, feel free to mark that. The world is certainly aging, and this is a good thing. It's a testament to all of the work you're doing, advances in healthcare, societal changes in public health, that have resulted in improved longevity and decreased mortality across really all stages of the lifespan. Now, with that, the question has always been, how will we care for these older adults? And this is not something that's new to any of you in the room, but I just want to make sure we're all on the same page. And it's also pretty clear that geriatrics, and as a field, has a numbers problem, and this is not new news to anyone as well. But conservative estimates, assuming that we were at a steady state in 2018, you were meeting our supply and demand. Many could argue that we weren't doing that at the time. If you extrapolate that out to 2030, and this data comes to the American Geriatric Society, we will have a 50% increase in need for geriatricians within the next, I guess that's 12 years or so. And this isn't just a geriatrics problem, it's also a primary care physician gap as well. And more data from AGS shows that, we've been doing okay keeping things steady from 2017 to 2021 as the number of fellows in geriatrics entering geriatric fellowship was relatively steady, but with those increased demands of with increasing older adults, we aren't going to meet our mark. Now, unfortunately, this changed in 2022, and and many of you are aware that, as a whole, our Geriatrics fellowship match didn't do as well as we would hoped. And only 177 of the 411, which is about 43% of those positions, were filled, which was the lowest percentage of all fellowships, all the 71 advanced fellowships in medicine. And so I encourage you to read this JAMA Viewpoint, which many of you probably have already read, from Jerry Gerwitz of the University of Massachusetts, who talks about how, why about these challenges and why there's been a paradoxical decline of geriatric medicine specialty. If you don't like to read like me, you can always listen to the Jerry Powell podcast, which talks about this at length, with Ryan Chippendale, who's the program director over at BU, and Mike Harper, the other UCSF folks. And the quote I like to think about from this is, well, the importance of the profession of geriatric medicine, while the importance of the profession of geriatric medicine and the need for geriatricians seems obvious, it's to not surprise anyone that is the career choice of ever diminishing numbers for medical students and residents. Not to bum you out with that, but that kind of is very sobering to me as an educator. Now, things got a little worse over the last few years, and many of you noticed. I pulled this data from the ERAS statistics that were just published a few months ago. And after 2021, there's been even more of a decrease in geriatric fellowship applicants. As well, Kate says it's hard to bum me out. Yes, and the goal is not to bum you out, so we'll get there. But there's been a decrease in applicants. Now, that being said, I've seen fabulous fellows come through, and every year as we interview, I feel like the quality of fellows also is super strong. And I see the fellows that match you guys. I get to meet the HES and folks with us, so I'm not bummed out. I think that there is a light at the end of the tunnel. Now, does it really have to be this way? Other developed nations from across the pond. I guess that also assumes that the United States is a developed nation, which may be a stretch at this time. Doesn't have a problem with consult geriatricians numbers. And there's around 1,700 geriatricians in the UK. And geriatrics is actually the second largest specialty, only to cardiology. And yeah, there's differences in their medical training, and they have a queen and they drive on the wrong side of the road. But I think it doesn't mean that it has to be this way. And we have to think about what we can do to improve the numbers of geriatricians and healthcare training for those who care for older adults in the world. So, I just put out this, some of the things that we need as a whole. Clearly, we need more geriatric experts. We need, and also recognize that many folks aren't going to be geriatricians. They are going to care for older adults. So how do we train those folks? We need more geriatric training for the health workforce. Things that we won't talk about in this talk, but certainly are just as important, are more public education to empower older adults and caregivers, and certainly some health policy changes. So some of that has already been dropped in the last year that can help support all of us as we age. And thanks, Kay. Yeah, there's a lot of cultural there certainly are a lot of cultural differences too that contribute to that. So what will we talk about in this talk? We'll talk a little bit about how we can provide more geriatrics expertise and create those geriatricians and build that pipeline. And I'll talk a little bit more about how we can train the whole healthcare workforce to be more age-friendly. And so how do we build that pipeline of future geriatricians, which is a lot of our life's work here for those educators in the room? And to think about this, I want to think a little bit about your origin story. And so this is I love a good superhero comic book origin story. And the reason I bring this up, well, I mean, think as many of you may forget on a day-to-day basis, I view you and you all are superheroes for the way you take care for and study older adults, and so you're superheroes in some way, shape, or form, without spidey senses and other traditional superpowers. But I want to think about what was the origin story for your career in geriatrics. Who was the first geriatricians who you met, who influenced you? So I'm going to take a few minutes and give it an awkward silence a little bit, unless you want to unmute or put it in the chat. Put in the chat or unmute and tell us, like, who were those geriatricians that you ran into early in your career? And I'll tell you about mine, but I also want to see if you all could throw some names in the chat, maybe a little bit of an anecdote.
Oh, hi, Matt. I just
Oh,
wanted
hey, May.
to my science mentor early on, and Kate knows him, Dr. Finkelstein. I don't know if you all knew him. He was John Wonigat's mentor, my
Oh,
mentor. He was our representative sort of at NIA. And he used to say that if we start out our research questions with apologies for doing what we're doing, that it's going to set us up for a spiral of lack of success. So he used to always coach us to start out with a sort of an upbeat. Um, these are the pros of working on cellular aging or aging in general, and I always found that lesson very important.
oh, I love it, May. Thanks. I knew I could count on you to break the silence. Uh, let's see. And then Tom mentioned Margaret Wilson at SLU, St. Louis, and who trained in the UK as well. Thanks, Amy, who met their first geriatrician in medical school, worked with them in the hospital and SNF. Let's see what else. And then Kate was in the University, Washington University of St. Louis, and also worked in nursing homes as well. I think Kay met folks at a home-based physician and rotations. Thanks. Hey, Rima. Over at Sinai, lots of good geriatricians in there. Oh, I know. That's wonderful. So thanks for sharing. I hope you all thought a little bit about yourselves a little bit, and maybe you can learn a little bit about each other. Oh, hey, Annie. Oh, Sharon Inaway, of course. The delirium queen over there, and Bill Hazard, Inamar. All right. So a bit about my origin story, since you asked me to be here, so you're forced to listen to it. I grew up on a fruit and vegetable farm out in Central California. I was born in Seattle, but we moved down there. Kid. And outside of Fresno is basically Eastern Washington equivalent. And so I grew up picking fruits and vegetables on the weekends with my Japanese grandfather. That's him on the top left, with his brother, who started the farm after they returned from internment camp in World War II, after World War II. And, I spent the weekends and summers there. Wasn't the most pleasant experience, to be honest. So when I went to college at UC Davis, I wasn't sure what I was going to do. I was pretty sure I wasn't going to be a farmer. And so I dove into some experiences and volunteered at this Samaritan Center, which is in Visalia, just down a few miles down the road, which was a free clinic in the pre-Obamacare Affordable Care Act days, where I helped care for uninsured farm laborers and the same folks who I worked with in the fields and the fruit packing sheds. These formative experiences kind of built my interest and desire to care for folks who were underserved and had trouble accessing care, but I wasn't really sure what that meant to me long term. And so I went to Johns Hopkins, and in 2010, I had a broad differential of what I was going to do. And whether it be through luck, fate, or just odds, Danelle Kea on the top left was my assigned mentor, geriatrician, and also a fabulous educator there. And that program is similar to the college's program that Ruru mentors folks in. And so I remember she sharing when I got there, I think, and she said, "Hey, I asked her what she did, and she's like, I'm a geriatrician." And I just remember clearly thinking, nodding and smiling, having no idea what that even meant at the time. It didn't take long for me to figure out what she did and why it's a fabulous field. And eventually I was pointed towards internal medicine, primary care. And I had some really formative experiences with Tom Finucane, who's in the middle there. We taught me really how to question how our healthcare system cares for older adults, how to best care, why older adults need subspecialty care. And I ended up going to Seattle in the primary care track, assuming I was going to do some sort of academic primary care. But in March of 2016, during my R2 geriatrics block, Tom took me out to the SNF, gave me a lot of great teaching, and he also had me order lunch and got me a fish fillet sandwich from a skilled nursing facility. which was also a very formative experience. And he actually planted the seed. And the first time someone actually said, "Hey, have you ever thought about being a geriatrician? Consider geriatrics. I think you'd be good at it." And I never would have thought about it until someone actually planted that in my head. And so it was very important. So I obviously hit up Kate, and she took me out to coffee over the Pat Steele building, bought me a latte, and I thought, oh wow, if she can buy me a latte, geriatricians must make plenty of money. If and she quickly convinced me that I should apply for fellowship, and that's where I am today. So I guess in retrospect, my radioactive spider was Ton's fish fillet or a Pat Steele latte. But in all seriousness, it was most likely the early exposure to geriatricians, clinical experiences, mentorship, and sponsorship that really brought me down that path. And as I read Mary, it looks like, oh, Liz Phelan, hi there, and David's comments, all of these folks had, except unfortunately, Mary didn't have an undergrad class about older adults, but most folks had, if not all, had some geriatrician that inspired them to do what they did today. And so I want you to think about that, and maybe perhaps there's folks that you don't even know that you inspired that don't come back to give grand rounds, but who are geriatricians today because of the work that you all did. Although it's a small field, so you probably know. So from the next few slides, I want to share a little bit about how I'm doing my part to pay it forward and build a pipeline of geriatrics by providing some of that early clinical educational experiences and overall training for the future and current workforce over here at Stanford. So we'll start by some of the undergraduate ed work working on. And so back in 2020, as Kate mentioned, there was this pandemic, and it really put a pause or shut down all of the educational experiences here at Stanford. But that gave us the opportunity when things were opening back up in 2021 to revamp what we did with our Geriatric curriculum. And at the time and to this day, we really only have 4 hours allotted in the 4 years of medical school, or 2.5 years of PA, 2.25 years of PA school, to get geriatrics into folks' brains. And so I thought to myself, ooh, what would Kate do? And so we put together a 4M based curriculum based off of some of the teaching that me and my colleagues were able to do with Kate with the medical students. Some workshops and 4M based curriculum with a mobility session on the bottom right there, with us, which had a small group fall prevention workshop with a gait assessment. It's multidisciplinary. We drag a physical therapist in there to help teach gait assessments and mobility aids. On the top left, there's a mentation and mind session where we use a VR dementia simulation with our fabulous clinical nurse specialist who puts students kind of in the shoes and in the brains of someone with cognitive impairment. In the next slide, we have a polypharmacy section on the bottom left. Pill boxes, flicking liquids, beer lists, and all of the good polypharmacy stuff. And I'll talk more about what we did for the What Matters piece in the next few slides. But since this is a research grand rounds, I have to share a little bit of the data that we're able to present at AGS. Of the 120 or so MD and PA students, we were fortunately able to show that they felt more comfortable on their confidence on assessing older adults in the 4M model, using interdisciplinary team members, having understanding how folks how to interact with folks with cognitive and sensory impairment, performing fall and balance and risk factor assessments, and how to find resources to assess older adults, medications list, beers list, etc. And so a bit more. Oh, and then on the bottom here, there's my mentee, medical student Richard Ling, who was able to present this work over at AGS at the education workshop session. So what more about what matters? And I want you to think a little bit about what were some of the salient clinical experiences from your origin story. So if you want to throw that in the chat while we talk, and I'm going to look at some of the chats too as well. So as we think about how we care for older adults, I know many of you had a one or many clinical experiences that shapes or solidified your path to becoming an expert in care for older adults. Here's Mr. J here on the left, who I saw, I think, every 3 or 4 months in my continuity clinic over at the Roosevelt Clinic in Seattle. I worked through his chronic conditions, his geriatric syndromes, his loneliness and isolation. And for those 3 years. And on the last clinic, he brought me 2 frozen trout there. I think I had to look, I kind of freaked out. I was like, am I allowed to accept this trout? I probably shouldn't give it back. So we took it. But really, he solidified that, hey, you know, why did I become a physician? And it really was to be someone's doctor. And that continuity and that patient relationship was really important. It reminded me why you'll have to rip away my primary care role over at Stanford. And then I can't help but share, I think Kay knows this, these folks, the 2 folks I cared for at the CLC as a fellow, and I think a lot of you probably care for them as well. And, you know, these vulnerable veterans taught me about the challenges of balancing the risks and benefits of autonomy, living alone, sniff delirium management, and really so much more. And it solidified my path to work for and advocate for vulnerable older adults. And the picture on the bottom left is when I played hooky from fellowship and went with them to Seattle with the rec therapist and went to the Seattle Aquarium. Sorry to Anne Froelich, because I don't think I did my orders in time that day. And thanks, Kate, for covering me. But really, how do we share these clinical experiences and these patient stories in a consistent fashion with trainees who may not be able to get those clinical experiences with folks? And let's see, I'm just going to look at the chat here while we're here. And let's see. Oh, Rima talks about her mandatory geriatric rotation at Sinai. And so thanks for sharing that. Okay. And so how do we share what matters with older adults? And I think it's through sharing these patient stories. And this was during our second round of sessions where we brought patients into the classroom and helped them and shared those stories with our students. And I want to argue that, you know, bringing patients into the classroom is really meaningful for students and our patients. And so one of our fabulous educators, Lindsay Haddock, one of our geriatricians here, and I have been bringing in students into the classroom, and we interview them. We ask them what matters. We talk about what's important. What are the challenges with aging and caregiving, dementia, with caregivers, we have patients. And we felt like, this has to be salient experiences, but we probably should look at it. So we looked at 2 years worth of students who participated and got about 41 of them to respond. And we actually surveyed our patients, family members, caregivers as well, who we dragged in as well to respond to this survey. And what's clear is that it is meaningful for patients and the students. And some of the patient perspectives that come out, that patients actually feel really satisfied to contribute to the education of future medical professionals. They just hope young students will take away something that will employ them in their future patient interactions. They're inspired by the students. It's therapeutic to share their experience, and they learn from other panelists as well. Students take away a lot as well, as you'd expect. It's hard for me as a physician to share exactly what caregiver burnout and fatigue is, social isolation, but when a patient or their family members tell you, it's so much more meaningful. They learn a lot about the communication, working with compassion, and geriatrics as a team sport. Where did I get and I guess another citation, where did I get the idea to bring in patients in the classroom? Well, again, it was from Kate, because back in 2017, she, I think this is your patient, we had the Being Moral Book Club as part of the School of Medicine rotation, and thought, oh, geez, what a novel idea to bring a patient into the classroom, ask them to share their stories. It's very logistically challenging by no means, but also very worth it. So what are the other ways that we've been able to get geriatrics in the classroom? I teach the Being Mortal elective. Our Stanford students are able to take electives at lunchtime seminars during their first and second year. And so for the last 2 years, Deb Cotter was on the bottom left and Mimi Dunn up on the right. Deb's our section chief of research, and Mimi's adjunct in emergency medicine, palliative medicine. We've been teaching this elective where we bring speakers in from a diverse group of speakers. We have a chaplain, Laura Carsonson, who's an aging researcher. There's Louise Aronson on the bottom left, with the author of Elderhood and others, to teach and inspire a multidisciplinary group of students. This includes medical students, PA students, we get business students, we get these distinguished career fellows, undergraduates, grad students, as well, knowing that, like, hey, yeah, the odds are we're not going to get a geriatrician from this, but potentially we'll get some age-friendly folks who will do their part to care for older adults in the way that they. Great. So we'll shift gears a little bit, and our next objective is to identify how developing community partnerships can advance age-friendly care with those who don't have access to geriatrics. And it's very clear that we won't have enough geriatricians, but we have to figure out how to ensure older adults get age-friendly care. So in order to understand this need, I started to reach out to our community partnered and build community partnerships with clinics and FQHCs in our greater Santa Clara County, San Mateo County, Alameda County area, basically the Greater Bay Area. Kind of inspired by the UW Project Echo work, I thought, well, there's all these folks who care for older adults who aren't going to be geriatricians. What do they need to take care of older adults? And assuming that maybe it's some education, but we probably should ask. And so I interviewed some key stakeholders, medical directors, CMOs, family medicine leadership from their residency program in San Jose, current family medicine residents, and all non-geriatricians. And I surveyed some of the medical directors of the Santa Clara County FQHCs. And I'll share some of the themes that came from this. All of them wanted some help with the things that you all are good at, teaching folks about dementia, cognitive impairment, polypharmacy, advanced care plan, goals of care. They all thought, well, come and give some talks and bring some challenging cases. But what was also clear is that I say, hey, they all said in various forms, hey, that's great, you're interested in teaching folks. You can come give lunch talks, but sometimes I really need help for specific patients and specific clinical scenarios. And my patients can't access your geriatrics consult clinic or your senior care primary clinic due to all of the reasons: insurance, language barriers, access in our own clinic. And so could you do some e-consults to help out? What are those geriatric e-consults? Well, they're these they're asynchronous provider specialist communications, often utilized by primary care subspecialty expert opinion. When you have a question, it's a formalized curbside in many ways. The consultant will look at the question, review the chart, and give some best practice advice. Certainly, there's growing data that it can improve access. It's not quite clear if it improves outcomes in subspecialty care, and there's very limited evidence for using these in geriatrics. Here's one of the few studies from e-consults for behavioral symptoms of dementia done by some of our colleagues over at the Palo Alto VA, which looked at the e-consult interventions that they did, and they essentially provide better access. They got some medication guidance and saved a lot of miles traveled for our veterans, but not a lot going on there. It is important to question, well, can these e-consults be helpful in the community settings, the FQHCs? And this is some of our colleagues here at Stanford who've been piloting e-consult and all of the other specialties within the geriatric, including derm, endocrinology, gastroenterology, ID, et cetera. And um, and from this, they are able to show that, hey, the majority of time we are able to influence care in a timely manner with it, which is in 1 to 2 days, avoiding referrals almost 70% of the time, and often making new diagnoses a quarter of the time, and providing that treatment within primary care clinics. And they're rarely punting to different specialists, which is also nice to see. Every once in a while, folks do need to be seen in person, so that's that 15% there. But for the majority of the time, they're providing access to care in this setting is Ravenville, which is an FQHC in East Palo Alto, down the road, without having the patient having to drive, deal with insurance, scheduling, etc. It's important. Just checking the time. It's important to think about, well, when you build these community partnerships, what do they have to be? And this is something I think about often when I'm meeting with these folks. And so I work closely with our Department of Medicine community partnership program, which builds that framework of how you build these partnerships, whether it be educational, clinical sites, etc. All of these things have to be bi-directional, built on trust and respect and authenticity. So something that I encourage, as you all build partnerships in the community, think about when you're working with groups that, well, aren't paid by your institution. Next slide is, I think it's great, Matt. You said you can do e-consults, and it sounds like that's something you might want to do. Well, do our primary care providers actually want that help? And so we surveyed our division of primary care and population health, and we got about 50 responses of mostly physicians, some APPs, and a few other providers. Would they want geriatrics e-consults? And the majority of them said they would utilize it relatively frequently. Some said they use it weekly. Some folks take care of a lot of older adults. Many folks said monthly or quarterly. And what topics were they interested in? Resources for older adults, polypharmacy evaluation, and then really the most biggest pain point is we have a lot of trouble with access to dementia care at our institution. Not unlike many places, is dementia diagnosis and management. Now, how much of that can be done in e-consult? Well, we'll see, but certainly folks can get things started. And so this is some of the work that our one of the medical students we mentor, Benicia Patel, and one of our other faculty members and myself put together. So what's next in the journey of community partnerships and geriatrics and our timeline? Well, we started with some needs assessments. I didn't mention that we also have been doing didactic case conferences and didactics into these FQHC partnerships throughout the county. We're working on formalizing curriculum and making it count twice and getting educational opportunities for our faculty and fellows. And right about now, we're responding to our needs assessment, and our goal is to pilot an e-consult program in the next few months. And from there, we can make it count 3 times and create a e-consult elective for our trainees as well. All right, so that sums up a lot of the educational efforts. And with the 10 minutes or so we have left, I want to describe how formalized age-friendly care pathways can improve delirium outcomes for geriatric trauma. And I know this is a little different from the educational work that I promised here, but I thought, well, they may never invite me back, so I might as well send it, as the kids say, and throw out everything that I've been working on. Because as you know, I think all of us know that it's important. Geriatrics are important and valued. We know that we need more. But unfortunately, many healthcare administration, many folks may not also believe that. And so unfortunately, we're tasked with showing how we bring that value. So I want to talk a little bit about what we've been doing with geriatric trauma, also known as what I took from MedG to California. Let's see here. A lot of these slides are from our fabulous fellow that we mentored, Carolyn Park, who's now a geriatrician down at the University of Southern California. What you all work, actually, I'm looking at most of you work on MedG, And and so the challenges with geriatric trauma and the need for improvement in clinical outcomes. Not unlike other slides, there's a lot of older adults, there's a lot of geriatric trauma, like every other geriatric syndrome. If you're older, you have worse outcomes. And there has been some data and showing that multidisciplinary pathways for older adults that are frail can improve delirium outcomes in other places. Certainly, there's a lot of hip fracture, orthopedic data that's out there as well. And locally at Stanford, we have the same challenges. There's been increases in geriatric trauma on those 65 and older. A lot of the trauma that's not hip fracture is non-operative, and ground level falls are bread and butter. It's one of the more common mechanisms in injury and would have increased problems of complications and higher costs of care. That is not news to anyone here. And so this work started before I showed up, and so I can't take credit for all of it, or most of it, frankly. But our goals were to really develop this partnership with trauma that started back in 2016. And with the goal of developing
How's it going, Cindy?
Oh, hey.
Happy Friday.
Older pathway for older adults incorporating age-friendly health systems with the goals of value improvement, culture change, advancing equity. That's a two-foot slide there. And so where the start, well, there were, before I got there, there were targeted geriatric trauma consults. We really only had one geriatrician and one clinical nurse specialist at the time, where we work closely with the trauma folks to get to show value by seeing their patients being there. We helped them develop their order sets. We piloted a new ACE unit in 2017. But as I was showing up, it was becoming clear that, like, yeah, this is great, but we're missing a lot of folks. And so 2018, around the time I was joining 2018, we started the journey to developing a formal trauma care pathway. And I'll tell you more what that means. Since then, other things in the hospital have been cooking, like a geriatric emergency department. We joined the IHI Age-Friendly Health Systems in 2019. And then I was the medical director for our ACE unit that started in January 2021. And so we've been working on a number of things in the past few years. And so I'll tell you a little bit about this journey and what we've been able to do. And the punchline is, well, we were able to show that there's some associated changes in delirium rates in older adults. For those with geriatric trauma, this is trauma surgery. Caroline Park is our first author, the fellow you saw before. Ankur Barija was the other geriatrician who I joined and did a lot of the groundwork in getting this moving. And Kristen Sotomayor is our trauma surgeon lead from our group. And, not unlike any other geriatrics programs, well, it takes a lot of teamwork, multidisciplinary care with representatives from and buy-in from all of the different folks here. Pretty much all of the things good geriatricians think about. What did that actually mean when we say it's an age-friendly trauma pathway? Well, we identified all the 4 M's and how we can improve and study those in older adults who are affected with trauma. A lot of this work was done by our geriatrics team, aka me and one other faculty member and a clinical nurse specialist and a few trainees. And so it's identifying what matters, measuring times to completion of our advanced care planning documentations and process metrics, medication management and review for potentially inappropriate medication that was done by our geriatrics team. Since then, we've added some pharmacy help for that. Delirium screening that was done by nurses, and we did a lot of nursing education on how to do the CAM. And mobility, one of the biggest lifts was getting buy-in from rehab and nursing to automatically consult for all patients with trauma and start documenting the times their first mobility from their admission, knowing that the majority of folks should not that are admitted that trauma service should not have any restrictions with their mobility. Just like every other good geriatrics pathway, we have to do some work on the healthcare records and workflows and order sets, arranging automatic consults, setting expectations for documentation and some algorithms for how to manage pain, making sure that getting rid of all the Benadryl and the Ambien on the order sets and the Colace, and getting the Miralax and Senna scheduled. And so we standardize all of that work. And so I think this is a little bit redundant, but what were some of the daily workflows? Well, we had a multidisciplinary ACE type meeting during the weekdays for the floor patients. We consulted a transitional care team if we felt it was appropriate. And then we did a lot of fall prevention as well, knowing that folks who are at fault, who came in with a fall are likely to fall elsewhere. Huge undertaking with institutional support from our quality folks to develop all the sexy dashboards and monitoring things like length of stay, the process metrics that we talked about there, CAM and delirium outcomes as well, and had to standardize a lot of the EPIC documentation around pain scores, activities, and this was a big lift and buy-in from our nursing staff, and so we really appreciate that. And so the questions were, well, hey, if establishing this pathway, is that going to help with improved outcomes for older adults? And so to study that, we did a retrospective case control study for these older adults and compared our our baseline population to our post-implementation population. And this pathway excluded folks who had surgical outcomes, and which often have other care pathways that might interfere with results. Here's the data from our table 1, showing some of our baseline characteristics of our baseline and post-implementation studies. I'll skip ahead to some of the unadjusted clinical outcomes, and for all patients, we found a reduction in delirium outcomes. And that was post-implementation. We didn't report the mortality data. The numbers are too small to be accepted. So we'll have to run that later. And hopefully we'll get that out in the next year or so. Looking at the delirium outcomes for the baseline cohort, we saw a reduction in delirium in really most of the cohorts studied. I'll skip some of the process metrics that we looked at. We looked at pain control. Interestingly, pain scores that increased. We're not really sure why that's the case. Perhaps it's a better training on how to rate pain, maybe more. It's not entirely clear what that's about. We're some non-statistical differences in hour first ambulation, but we were able to show that we were able to have more earlier goals of care discussions with them for those who are staying longer than a few days. So to summarize this work, our care pathway was associated with a reduced delirium rates in older adults into the trauma service, and potentially this is highest in those with lower severity scores. We didn't have time to dive into this more, but reductions in the rates of delirium were more common based on demographics and sex and primary language. Places where we should look at closer. We talked about the pain scores. So this care path was inclusive of older adults, age 65, and we didn't select those high-risk folks, which we think is a strength. It's consistent with other care pathways that showed improved outcomes in geriatrics trauma. And this was the first study to implement geriatric-centered age by trauma care with using the 4 M's as kind of the framework. The limitations with doing all the work was here at Stanford is our population, which is primarily Caucasian English speaking. Liz, hey, what do you think the mechanism of delirium reduction was? Well, I think it's is it a cop out to say multifactorial in geriatrics? I think that's kind of what we buy into. There's so much that was done from a nursing, ACE unit, medications, mobility, really reframing how the surgeons take care of patients, constipation prevention. I wish I could put it, and maybe there's something we could look at later if there's something that will be more something that will come out from the data. But I wish we could boil it down to one thing. I mean, certainly we got rid of all the Ambien and Benadryl from the order sets. That's certainly part of it. But just like all of the good ACE data, all of the AGS co-care help data, all in order to really reduce delirium, it can't just be one thing. And so I do think it's really creating these age-friendly care pathways to improve delirium. And I think delirium is a good geriatric syndrome to show that. All right. Oh, and then here's our authors. I have to put a big gold star over Caroline, who helped create most, if not all, these slides, and was the lead author, one of my our fabulous fellows who's, like I said, down faculty. You'll see her at AGS probably. Look, right on time. So I hope, in summary, you're able to reflect a little bit on your career path in geriatrics, and from there identify future opportunities for you to continue to develop the pipeline of future geriatricians. As I said, there won't be enough geriatricians, so we're tasked at figuring out how to provide that age-friendly care for those who don't have access. And I'll let you know if e-consults are maybe something that can help meet that need. And then as we finished with multidisciplinary care pathways have the potential to improve delirium outcomes. I suspect they'll improve other outcomes as well. And so further work is to be done, as always, to replicate that in other settings and other clinical scenarios. So those were our objectives. This is my GACA mentorship team: Christine Gould, who I think was in Kate's Tideswell cohort; Erica Schillinger, one of our educators here; many of you know BJ. Jonathan Shaw helps me with a lot of the community partnership work, and Deb Cottas for our research chief here as my primary mentor. And so I would love it if you filled out this evaluation form here that was kindly provided to me. And I will, in return, I will show you all my favorite pictures from American Geriatric Society. And there's a couple more, I think. And so I will end with this. If we have a few minutes for discussion. So, what other innovative strategies should we be focusing on or to inspire, motivate trainees to pursue geriatrics? How else can we provide geriatric education and clinical expertise to those without access to geriatricians? And so a special thanks to all of you for all the training and teaching I could give you. I think everyone on this call, it would take me I thought about just spending the hour looking at everyone's name on here and telling them something I'd learned from them, because there's certainly at least multiple things from everybody. So I want to thank you for all of that, and thank you for your time. And so please reach out to me and add to the discussion now. But reach out and email me if you want to talk more about geri education, inpatient geriatrics consults, geri trauma, community-based work, and a number of potpourri things that I've been keeping myself busy with. So thank you again for your time. Oh, there's a link for the evaluation too. Liz mentioned, did you look at it? We did not look at falls in our study, and that's something that I'm not that's something that I think we wanted to do, and that's something that's a good idea. The in-hospital falls, I think, as you know, are very tricky. Sometimes I think we do think I think I'm hopeful that it would decrease the in-hospital falls. There's a lot of variability in the nursing care from unit to unit within our hospitals. We have a new hospital, an old hospital, and the nursing staffing ratios, actually probably more importantly, the nursing aid ratios are very different in those places. And so I'd be interested to know what the falls look like. And so that's something that I'm hopeful that's a good idea to look at. Thanks, Dr. Phelan, for that. Other questions or anyone else want to add to the discussion?
Matt, you are doing amazing work. You've done so many things, and I appreciate you sharing it all with us. And I really appreciate the trip down memory lane with the photos that brought joy to my morning here. I think that, I'm always hopeful and optimistic about geriatrics, but I think the fact that Medicare is paying attention to age-friendly and putting some financial penalties around age-friendly care and forcing our health system into making these positive changes, like the things that you've been doing at Stanford, just because it's the right thing to do for patients. The fact that that's being disseminated, if we bring trainees along with that, there's a huge opportunity to see the difference that you can make with providing excellent care to older adults and to see geriatricians leading those efforts and using their expertise. I think it's a great time for us to shine and have an impact.
Thanks, Kate. Yeah, the CMS measures are huge, obviously, and it's funny. I don't want to throw my institute. Ooh, I shouldn't put. Be careful what I say. I think it's even places with a lot of geriatricians. It's we still have to fight to get at the table when we're implementing those measures, and so work. And I've learned a lot working with. We've been working with administration from the hospital side on how to best meet those CMS measures, and how do we balance highlighting what we've already done and how we're already meeting some of these things with also saying, hey, but I need more resources to do more. Like, hey, I can check these boxes, and we can check some of these boxes right away. But actually, if we want to do this right, we should probably and we should do this right, because at some point, folks are going. It's not just checking boxes; it's actually showing outcomes. We're going to have to invest a little bit in that. So you're right. I think that's it is refreshing to see that, and to see that buy-in from kind of the top down and some trickle down effects, hopefully, that can eventually get to our trainees. Dr. Phelan, oh yeah, this is our the GACA project that we're working with, the community partnered FQHCs is what I've been working on. So this is the majority of the GACA work, and some other stuff I've been working on too. May gives a let's see, a link to geriatric physician loan forgiveness, which I'm going to open up now. Thanks, May. I'll have to look at that later. Cool. Let's see. I just want to make sure I don't miss any of the other things in the chat. Oh, hey, Jenny. Nice to see you too. Cool. Other questions or comments? Thanks, Kay. Thanks, Liz. Hi, Annie. Thanks.
You're getting lots of
hey,
thanks.
yeah, I see that.
Thank you so
I'm gonna
much.
shout it out. Yeah.
Yeah, you
And
should
I will see you in
screenshot
Chicago.
this. Yes, we'll see you in Chicago. And I think in a couple years, there'll be a fellow who graduates who gives a similar talk and puts your picture all over it, because you're doing some great things.
Oh, thanks, Kate.